So why a neurosurgeon talking about placebo? I don't know, but I think it's an interesting topic. So I have no declarations. I'm really right-handed. So I don't think we have to worry about that here. One of the reasons I chose placebo effect is I think it's become more and more apparent to me as I get older that we don't have free will. We think we are in complete control of our universe and our medical care system, and yet we don't. We're driven as organisms by evolutionary traits that we've acquired over millennia, and those turned into these cognitive biases that are mostly subliminal to us. And if you want to read a good book, and I quoted at the end Kahneman and Tversky's book, Thinking Fast and Slow. Kahneman won the Nobel Prize and developed the field of behavioral economics. And he goes into a lot of these cognitive biases that are present in all of us. And the one I'd like to focus on today, in addition to the placebo effect, is confirmation bias. That is, we look for things that confirm what we already think we know, and we ignore other evidence that might be to the contrary. So why did I put this up here? Well, I think it's interesting because it proves a point, and that is we, as humans, looked up to the stars, and we thought we saw these heavenly bodies. We thought we were the center of the universe. We thought, gee, all these lovely stars, that must be all there is. And then along came Copernicus, who put the sun in the middle of our solar system using math and science. And then we thought we had it all down, nailed down, and that it was a static universe. And then along came Einstein with his field of relativity, general relativity, in the 1915. And even he said, well, my theory predicts that the universe is either expanding or contracting. And since I know it's static, I'm going to put in this cosmological constant to make it static. So he fudged. And then it took until 1933 when Edwin Hubble, looking at the redshift of planets, saw that the universe was expanding. And at that time, we didn't know expanded by how much and how fast. But since then, using studies of pulsars, Saul Perlmutter at Berkeley looked at pulsars 4 billion light years away and found that it was expanding exponentially faster. And so how do we explain all this? What is pushing the planets in the solar system and more than that, the constellations apart? Well, it turns out that the matter we see only accounts for 4% of this effect. That actually it's dark matter and dark energy that control 96 to 97% of the reason why this expansion is taking place. So we don't know much about what dark energy and dark matter are. There are a lot of people guessing. One calls it a WIMP, which is an acronym for weak interactive very heavy particles. So the bottom line is we don't know much about 97% of the universe because we can't see it. It's not in the electromagnetic spectrum. It's invisible to us. It's yet to be determined. Well, the same thing exists in medicine. And I think placebo effect is a way of introducing that concept, that the more I'm around, the less I know. And one of those reasons is the more you study the placebo effect in medicine, the more you feel that it pervades all of clinical medicine. And it's equivalent to the study of dark matter and dark energy. We just don't know much about it, but we're starting to learn. So what is placebo? Well, it was first seen in Psalms, in the Bible. In Latin, it means to please. The placebo effect is any medicine or intervention that has intrinsically no therapeutic value. So, i.e. the sugar pill that we all know we learned about. And it was a sort of a term that was held in a pejorative sense. He responded to a sugar pill. And we'll learn it's a lot more than that. So the nocebo effect is the sort of opposite of placebo. It's a negative effect created by something inert or an intervention. And an example would be the hysteria over gluten in our culture. Another would be the tendency we all have as physicians to medicalize everything we touch. Okay, so everything becomes a disease. There is no such thing as normal aging anymore. You can't have a skin wrinkle without it being a disease. If you look at an MRI report of your spine, oh my God, I'm dying, because they're all normally abnormal. And yet, putting that in perspective, all of us normally have these abnormalities as we age, and they don't mean much in a clinical vacuum. But they change someone's idea of their body, and that's the negative effect. The doctor told me I had a lot of arthritis on my x-rays. That's a stupid thing to tell a patient, number one. But number two, you need to realize you're affecting their life in a negative way. That's a nocebo. So what is a placebo effect? As far as we know, it's a psychobiological change occurring in the patient's brain after the administration of an inert substance or a sham physical treatment such as sham surgery, which we'll learn about. It was first identified in the 16th century with treating possessed patients, okay? People possessed of devil. They would give them a crucifix or other religious object and chase the devils away. And in fact, these people became less crazy and less disturbed. Voltaire, in his typical fashion, said that the art of medicine consists of amusing the patient while nature cures the disease. And that probably could be used today. Beecher, who was an anesthesiologist at Harvard Mass General in '61, noticed that surgeons who were enthusiasts, okay, relieved their patients' chest pains and cardiac symptoms more than the skeptical surgeons. So the guys with a bad attitude, you know, paid the price. Their patients paid the price for that bad attitude. People with a rosy attitude doing the same things had better outcomes. I've listed here some of the things that impact the brain that cause placebo effects that have been studied. Our emotions, our verbal cues, conditioning, expectations, learning, motivation. Thomas Jefferson remarked in 1807, one of the most successful physicians I've ever known has assured me that he used more bread pills, drops of colored water, powders of hickory ashes than all the other medicines put together. It was certainly a pious fraud. So it was heavily practiced back in the day. So what is a placebo effect? Well, if one looks at the total effect and subtracts the body's natural, quote, natural ability to recover from an illness, plus the negative or positive mindset the patient may have, or the social context that you're treating within, that's lumped together called the placebo effect. It turns out that if you study this, large pills are better placebos than small pills. Colored pills are better, red the best. Injections are much better than pills. Surgery is the most powerful placebo of all. And in a New England Journal article in 2014, someone estimated it was, looking at the studies done, it was 55 to 60% of people, if they undergo a surgery that wasn't indicated, but the surgeon did it well, will get better. So beware, and that's what we're going to talk about a little bit. They work best in a therapeutic envelope of white coats, hospitals, symbols of the science, and authority figures. A nice hospital physically is a better placebo than a rundown, shabby hospital. So kudos to the rebuilding. It's strongest when treating certain things. Obviously you can't cure cancer with placebo, although there's some evidence that it can impact the immune system. So it works best with things like pain, swelling, ulcer disease, depression, anxiety. It's a surrogate marker for everything that surrounds a pill, including the rituals, the symbols, the doctor-patient relationship, the therapist, the nurse-physician relationship, the patient relationship. everyone who comes into contact with the patient on any level, including the interior decorator of the space they're using, is going to have some share in the placebo effect. Homeopathy is a form of placebo. So a lot of placebo effect depends on our perception and expectation. That is, if we know we're getting something and we see the nurse injecting it in our arm, it's a much more powerful placebo than if it's done, you know, the nurse walks in and just shoves something in and you don't know where it's going or what it is. But the nurse walks in and said, "Now, Mr. Jones, we're going to give you a very good pain-relieving drug that's really going to help you manage your pain." And they're going to sit down and inject this slowly and the patient will watch. That's a much more powerful placebo than just walking in and surreptitiously injecting it. So this study was done with open or hidden injections of various pain medicine. And you can see that there was a much bigger effect if the patient knew and expected what they were getting. So there's real treatment effect here. It's not imaginary. So a guy named Ted Kapchuk gave a TED lecture. He's a physician at Harvard Medical School, and he studied in China, Asian, you know, what was called Oriental medicine at the time. And he's done a lot of studies looking at placebo effect, and he gave this TED talk, and I harvested a few slides from his TED talk. But he looked at irritable bowel syndrome and looked at those patients who just were signing out forms and they had no treatment, filled out forms, given a placebo but no engaged care, and then intake placebo plus engaged care, which means caregivers sat with the patient, explained things, touched the patient, and these were the results. There was a lot better relief in the patient group that had the placebo, the standard intake forms, but engaged care. So not only was the placebo pill active, but the engaged care was itself a placebo that helped in an additive fashion with outcome. So the days when those of us who have a history of being curmudgeons could be curmudgeons without some outcome problems are over. We need to have a nice face on. We need to interact with the patient, smile, encourage, reassure, and that's going to cause a much better effect than the austere, surly, into himself surgeon. So what's happening? Well, as far as we know, we're stimulating dopaminergic centers. You know, one's called the pleasure center, which is the nucleus accumbens in the medial frontal lobe in the floor of the frontal fossa, the anterior fossa. And the ventral tegmental area of the mesencephalon, the midbrain, is where the dopaminergic compounds originate, and they're deposited in the nucleus accumbens, but there's also a lot of chatter to the frontal lobes. And then there's also dopaminergic centers from the substantia nigra up into the nigral pathways, which are the caudate and the putamen called the striatal system. And that has a lot to do with our emotions and probably drives this behavior. We know that you can block the placebo effect. If you have someone with a certain stage of dementia who've lost frontal lobe executive function, they don't seem to respond to placebo very well. If you deactivate the frontal lobes with a heavy pulse of magnetic energy, which has been done to knock out various areas of the brain to see what happens, it's a reversible transmission blockade, then that seems to destroy the placebo effect. And if you're dealing with pain and you give a naloxone or Narcan, it seems to block some of the placebo effect because it seems that the placebo effect for pain relief works through the endorphin system, which is our body's own endogenous opiates, which we never knew, but now we do. So what other effects does this have? Well, again, Kapchuk at Harvard did a study where they did Pavlovian conditioning of patients with Parkinson's giving them levodopa and giving them a sugary, memorable drink at the same time, several times. And then they, on the third or fourth exposure, they just gave them the sugary drink. And if you do a positron emission tomography scan of the ligand of dopamine, you can see it's equivalent to taking a 250 milligram levodopa pill. So the body is actually locally depositing dopamine, and it has a therapeutic effect on the Parkinson's. Now, it's not a standalone therapy, but it's amazing that the body's doing this. It's learned just from a couple exposures to the association of the sugary drink with the levodopa to create its own levodopa-like effect. That's not the only thing. Here we see effects on the immune system. Cyclophosphamide is a potent blocker of cytokines, and along the cascade it lowers interferon, gamma, and interleukin-2, and then suppresses T cell function. And they've done studies showing that, again, under Pavlovian situations where you give the sugary drink with the cyclophosphamide, and then you do it a couple times, and then you give just the sugary drink, that actually there's a mimetic of cyclophosphamide administration. You see a lowering of interleukin-2, interferon, and suppression of T cell function that mimics cyclophosphamide. Now, these aren't huge changes. They're not enough on its standalone to give therapy, but it's definite biologic effects that have been measured in more than one human trial. Histamine response. If you give a loratadine, which is a histamine blocking agent, and you do the same sort of Pavlovian conditioning, and then you just give the sugary drink, they'll actually mimic the basophils will drop, the histamine, it will act like they have a loratadine on board when they don't. And even the allergic response will be less than it would have been without anything. So it affects the immune system, the immune response, neurobiology. Insulin has shown to be affected in these Pavlovian studies. Growth hormone and cortisol have been shown to be affected. So here we have so-called placebos affecting, and in the histamine response, you can tell someone the cream is going to make their rash better, and actually there's less flare, there's less reaction around it. So it's been studied enough to see that it's affecting the GI tract, the endocrine system, cardiovascular system, immune system, nervous system. So all these systems are under some control of placebo. So it's an extremely potent alternative, or supplement, better said, to conventional medical treatment. So how do we use this effect for therapy? You may recognize this guy. He's an Olympic swimmer. This is Rio. What are these things that look like he wrestled with an octopus on his shoulders? Michael Phelps. Cupping. Okay? Big believer in cupping. And he believes in cupping. Guess what? It will work, and it will improve his athletic performance. In fact, some people have suggested placebo should be outlawed for Olympic athletes because it does improve the outcomes. As far as we know, cupping, acupuncture, chiropractics, moxibustion have been studied in randomized controlled trials with sham of each one, and they're no better than sham. They're placebos, but they're placebos that work. So why should we tell a patient, oh, I don't believe in chiropractic? It's not science-based. Well, the bottom line is it's been shown to help people feel better. And if my own view is, if I'm sure it's not going to be dangerous, and if I think they're only going to see the patient for a couple weeks, what's the downside? So I encourage people to go to chiropractics with certain illnesses, because I don't know enough to say, oh, I'm better than they are because I'm science-based. And I think clearly they help some people. In several studies around the world for acute low back pain, chiropractic care is not only more effective, but less expensive than MD care, than physical therapy, than certainly epidurals. So, you know, why not take advantage of it, even if it is largely a placebo effect? There are plenty of things we do that are placebo, and we'll get into that. So here's what an educated MD who's into science-based medicine does. They ask themselves a question. Well, gee, 650,000 procedures each year of people with osteoarthritis of their knee, treated with debridement and or lavage. Is that good? Is that bad? It works, the doctor said, the surgeons. It works. We do 650,000 a year and a minimum of $5,000 each. You know, doesn't take you long to know how many billions that is. Well, it turns out it doesn't work. When you look at the outcomes, the higher the line here, the more the pain the patient had. The placebo line is here. They did the best. So sham surgery on the knee compared to the real deal, debridement or lavage. The sham patients followed 2 years, did equally as well. Gee, that's a revelation. Maybe that should change our behavior. That's what we need more of, but clearly it's hard to do. Sham surgery is hard to do. There's a lot of resistance to it, and I can agree. Here's another one. This was from 2013. Both of them are in the New England Journal of Medicine, with meniscectomy in non-arthritic knees. 700,000 of these puppies done a year in the United States alone, 700,000. And yet this trial, multi-center randomized sham-controlled trial, shows no benefit. The sham patients did equally as well or better. So again, science done appropriately with placebo controls, sham controls, should change our behavior. It doesn't always. So it turns out in a meta-analysis that was done of 53 sham-controlled surgical trials, 74% of the trials showed improvement in the placebo arm. 51% showed placebos did not differ from surgical results. That's over half. That's pretty scary. That over half of these operations were done and had no better than a placebo effect. 49 did, but even those, the surgery won by not much. So yeah, you should, as a patient and a doctor, have first, second, and third questions in your mind before letting someone operate on you, or a surgeon should ask those same questions before they operate on someone else. So here's a list of procedures that have been shown to be no better than placebo. There have been 3 randomized controlled trials without sham, but controlled to best conservative care, that show that low back pain from degenerative disc pathology doesn't respond well to surgery when compared to the best conservative care. So the insurance carriers who read more than we read, said, hey, guess what, guys? We're not paying for this anymore. You haven't proven to us that you know what you're doing. We're not going to approve low back fusion for low back pain in the setting of degenerative discs anymore. And that happened about 5 to 7 years ago. Doctors still find a way around it. They're creative. Hormone replacement therapy for women to hopefully reduce the incidence of cardiovascular disease. And then the controlled trials were done and showed there was a higher risk of stroke, DVT, and cancer. Why are we doing this hormone replacement therapy? It has to be individualized. I'm not saying none of it's indicated, but you have to worry about it. Fetal transplants for Parkinson's, heart and venous surgery for migraine, extracranial intracranial bypass graft except in a small group. vertebroplasty for compression fractures. The people who do this in our hospital say, oh, well, they didn't look at kyphoplasty. That's different. They just looked at vertebroplasty. Oh, okay. But there have been 3 trials with vertebroplasty versus sham controls without improvement in outcome. So one has to wonder. Radical mastectomy is probably the biggest negative against the medical profession and the misogyny involved in the late 1900s. It took Bernard Fisher and a very ardent woman journalist 15 years to get a randomized clinical trial that showed that if you randomize women with breast cancer, the outcomes are no better for radical mastectomy versus lumpectomy. It took them 15 years. Intradiscal electrotherapy treatment was a big thing 25 years ago. These brothers from Stanford touted this idea that you could stick a flexible probe inside a disc and heat it and, quote, denervate the annulus, and that would cure back pain. Tom Brokaw on NBC News showed a guy carrying his surfboard. I'm cured, I'm cured. And then they sold the company to Smith for $300 million, and then came 3 double-blinded controlled trials that showed it was a sham. It was no better than placebo. Renal denervation for hypertension, gastric cooling for ulcers, internal mammary artery ligation for angina, pougeage of the pericardium for angina, tennis elbow surgery. All these things have been pretty much disproven by controlled trials and should get our attention. So again, coming back to confirmation bias, I would call this foolish. Hopefully most of you would. We look for something that confirms our belief. What I would say is be skeptical. Look at what the facts say. Look at where the overlap is. But you know, this little area is probably overvalued. We need to do more trials to make these overlap more. So quantitative, comparative, controlled experiments in which investigators study 2 or more interventions in a series of individuals who receive them in a random order. That sounds good, and it probably is better than nothing, but be very skeptical of these trials. Those trials that look at composite endpoints. It's very easy to shake and bake the statistics with composite endpoints. It's even easier if we're looking at surrogates like cholesterol for heart disease. It's not an exact surrogate, but it's been conflated to be. Be very, very careful to look and see what the papers say about absolute versus relative risk reduction. Okay, oh yeah, there's a 50% decrease in MI with this treatment. Well, what is the absolute risk reduction? Well, it went from 1 per 200 to 0.5 per 200. 50% reduction, but which sounds more interesting? Probably the absolute risk reduction. Would you take a statin for an absolute risk reduction of 0.5, of 1 to 0.5 for 2 years? I don't know. That's a decision, but you need to do it with your eyes wide open before you recommend it to patients. So David Sackett, who just died in 2015, was sort of the father of evidence-based medicine, and this is his definition: the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. It means integrating individual clinical expertise with the best available external clinical evidence from systematic research. Again, I think it pays to be skeptical. I'm not saying don't do the studies. I'm saying do the studies, but do them well, and then be skeptical of the results and analyze them, because we've been misled more than we've been led. What we're doing today will look like the phlebotomy that was done during the 15th and 16th and 17th century. We're doing a lot of things wrong, I'm sure. It's hard to know which ones, right? Fusions for back pain, hormone replacement therapy, You take your pick, lung reduction surgery. All the surgeons said, oh God, this is great. If someone has emphysema, we increase the intrathoracic volume by reducing some of the diseased lung tissue. This works, no doubt about it. And then they did the trial that showed that the patients who lived had a better quality of life, although they may have been cherry-picked, but there was a 6 times higher mortality in the patients who got operated on. So I think the devil's in the details. We need to be skeptical, but we need to keep pushing ahead. And placebo is a big part of this. We need to realize if we're comparing this operation to another operation, that's fallacious. You know, you have to compare this operation to the natural history of the disease with or without a placebo. That's more correct. So it comes down to this virtuous cycle of improvement as imagined by Michael Porter, who wrote one of the books I'm going to recommend that you read. And unfortunately, we're not doing this well at almost any freestanding hospital in California. Maybe at Kaiser, they're doing this, where the physicians are captive audience and are doing what they're told to do. Maybe at some other places, the Geisinger Clinic, Mayo Clinic, but we have yet to have any meaningful, transparent outcomes because no one's doing the registry or the outcome measurements because it's cost too much or there's cybersecurity concerns. There's always a reason. This lawyer said, that lawyer said. The bottom line is we're not getting it done and patient care is suffering. We don't have the outcomes, therefore we can't change our behavior. Everyone's freelancing. Oh, I do fusions for this. Oh, I just do minimally invasive. I don't do surgery at all. Who's right? No one's looking. So these are the books, some of the books I'd recommend that you read. Worried Sick. Norton Hadler is an interesting guy. He's a rheumatologist by training. He's an emeritus professor now at University of North Carolina, Chapel Hill, trained in Yale and Mass General, and is a medical skeptic, if you will, and written a lot of books on what concerns him about the way we practice medicine in this country. This is written by an Australian man, Ian Harris, who I tried to get to come to our Saving the Brain, but he said, I won't be in your hemisphere that time of year. Michael Porter classic with Elizabeth Teesberg. I wish it were doable, but so far it hasn't been. This is a great book to make you think and to maybe change your behavior. It's written by Daniel Kahneman, who, as I said, was a Nobel laureate in behavioral economics, who was Israeli trained in psychology in the beginning. Now he's at the University of Chicago. So what I would say is holistic care is superior to body part care. Too frequently in our practices now, we're taking care of body parts. Oh, you have a back problem. Tell me about your back problem. And I hear it every day. And then the PA usually examined me, but the physician never touched me. And they said, go to pain management, get an MRI scan, and if that doesn't work, come back and see me. What they really should have said is, what sort of person am I dealing with here? What was your childhood like? My childhood was horrible. I'm not talking about mine personally, but frequently I get patients tell me, were you beaten? Yes. Were you sexually abused? Yes. I see you're crying. Okay, let me hand you a tissue. Well, it turns out there's a huge correlation between dysfunctional childhoods and chronic pain behavior later in life. You can't make that person well with an operation no matter what the MRI shows. It's like being on an opiate. They're hyperalgesic. And unless you get to know your patient by understanding the whole, you can't treat the disease they bring to the table. And no one's taking time to understand the patient. And not only the patient, but their social situation. So when we're dealing with things like pain, that's particularly important. But it's a shame that we're on the way to just assembly line medicine where body parts are looked at and we forget there's a patient there. So that's what I have to say today. Any questions?
I detect that you are somewhat surgically oriented.
Well, a placebo is inert.
Pardon?
It's inert. There's nothing in it.
Nothing in it.
Nothing in it. That's the definition of a placebo. A placebo effect is what it does in your body based on what expectations you may have, et cetera. Okay, so.
It used to be a sugar, well, I thought it was a sugar pill of some sort. It's not a sucrose or dextrose or anything? There's nothing in it?
It's inert. Well, it could be different things to different people, but,
Okay.
but placebo, the bottom line is placebo is not just a pill. It's a pat on the back. It's a warm environment. It's a smile. It's a convincing surgeon who says, you're going to get better.
But if you're comparing two different, a drug and a placebo.
It's anything done to you, anything done to you in any way that enters your senses is a placebo.
If they give you a pill of some sort or tablet.
And if they give you a pill and say this is going to help your pain, that's a very potent placebo.
And you delve into their history. How do the patients respond?
If they're just there to say where are you going to cut, doctor, then I can't help them. But if they're there to get better, then I can. There's all sorts of evidence now from Stanford, from Northwestern, from Yale, where people with chronic pain, which is defined as daily pain for over 6 months, they do fMRIs of their brain. They find out they have virtually identical patterns, abnormal patterns of activity in the forebrain, frontal lobes, medial temporal lobe, which indicates a very pathologic activation of those areas that's even predates the onset of chronic pain. So there's more and more evidence that chronic pain is a central nervous system disease, malfunction of the pain pathways. You can operate on the spine all you want, but the disease is here. And unless we understand that and try to reverse it where we can, maybe there are a few medicines that might help, but there are others in the pipeline for these. You know, there's some evidence that the descending inhibitory pathway, that synapses in the ventral, in the dorsal gray, that blocks pain impulses. That's why we don't jump out of our clothes, most of us. You know, we're comfortable in our clothes because we've adapted to the stimulus. Some people are so hyperalgesic, which means their pain threshold's lower, that their clothes are uncomfortable. So that's part of the descending inhibitory pathway. And so this is being worked out. It's in its infancy, but chronic pain is from all we can tell, is a central nervous system disorder. It's not, oh, I hit my foot, and now there's a problem in that nerve in my foot, or my back has been aching for 30 years. Please make it go away. There's no evidence that we can treat that disease with surgery. Now, if someone has a unstable slippage in their back and a nerve that's injured, that's different. That factors into the total, but that's not the patient I'm talking about.
Are you aware of, just speaking of hyper...
Yeah, there are genetic differences in how people respond to placebos. In the SAD disease, seasonal affective disorder, if you have a COMT, single nucleotide polymorphism, which affects your COMT gene, which is basically the metabolism for your epinephrine, norepinephrine, then it adversely impacts your response to placebo. And so there are genetic influences on placebo effect, but it hasn't been well worked out.
Basically say you're giving a pain med, but not give it. You know what I'm saying?
Yeah, Ted Kapchuk at Harvard did a study on this. He told patients they were getting a placebo, but he said it nicely, and he said it might have a beneficial effect, and it did. Guess what? So even if you tell the patient you're giving them a placebo, which I think is a good thing, they will many times, not always, have a placebo effect. So if you say it in the right way, with the right smile, with the right touch, I think it's perfectly legitimate to do. And we should take advantage of everything we can to help patients who are suffering. Even cancer fatigue has been looked at. Turns out placebos work great for cancer fatigue. Why? you know, it's this neurobiologic effect, but it's been studied, and it's been studied in more than one patient group. So chronic fatigue related to cancer has responded to placebo. So it's something that we all in this room can take advantage of, not just the nurses, not just the therapists, not just the ICU doctors, not just the surgeons, but all of us who touch patients can use this very powerful concept of placebo to work for us.
Thank you. Great talk. I missed the beginning. Can you tell me what led to your...
You know, I saw so many studies shooting down so many of the things I thought were helpful to people, including lumbar disc surgery. It's not clear that if you just choose a patient who's in pain, for instance, and who has a herniated disc, that you should be operating on that patient unless they're climbing the walls and can't live with it, because their studies do show that they tend to get better. Now, if they have a foot drop, or they can't get up on their foot when they're walking, then there's not good data to tell us about that group, because I've looked at that. And so I would tend to operate on those patients if I was very concerned about an advanced weakness. But so many experiences I've had that said, well, the kyphoplasty literature is not to be believed anymore. The IDET that I used to do can't be believed anymore. So there's so many things I believed in that have been shown to be ineffectual with evidence-based medicine and sham controls that I began to think, and then I started my venture into chronic pain and reading more and more outside of my specialty, and you find out that the mind is in charge. Many of these people are horribly injured from childhood. They've never had psychological counseling. They never have connected the dots. Oh my God, what happened during this time in my life is causing what I have now. Oh, you're the first person who's ever told me that. I started reading a lot about mind-body medicine. It has helped people that I've worked with. It's not surgical, but it's treating the mind. And some of this stuff is reversible. You don't have to know all the pathways or have the fanciest, latest drugs. Just sometimes the right cognitive retraining environment will make a big difference to someone's pain. And just having it out on the table. You know, John Sarno was a physiatrist at NYU. He died last year at 92. And he, in the 80s, was being sent all these patients that failed everything for back pain and neck pain. And he began to connect the dots that these people were injured. If you took a lot of time to talk to them, a lot of them had troubles they had never let out. They were just containing them in here. Anger, you know, job situations, spousal abuse, bad childhoods, the whole 9 yards. And as he began to talk to these people, he developed a way of sort of reprogramming them. And, you know, 75% of the people he treated who were open to his treatment felt significantly better after he treated them. And these were people who had failed everything else. So I think that experience, that reading.
What he's getting, does that make a difference in the effect?
Well, in that one study by Kapchuk, it didn't seem to matter whether they knew or didn't know, but I don't think we know enough to make a comment on that. I think in general we've thought that you have to make it seem like you're treating the patient. And yeah, but something as inobvious as the lighting in the room, the decorations in the room, the smiles on the part of people engaging the patient, that's all part of this placebo envelope.
But we know that there's a certain population of people who don't get better, and then lo and behold, they have their surgery, they don't get better.
Well, I think to treat the painful hernia without an obvious bowel entrapment, you got to understand the patient. What's bringing them to you with that complaint? How, you know, what's their life experience? What are they worried about? You can't just treat a hernia. You got to treat the person. So I'd go back to that and find out why they're there, why they're in pain, maybe things you didn't even think about. So chronic pain is not a local disease. It's a systemic, total body disease. mainly centered in the brain from all the studies that we see.